Here is a large sac and a smaller embryo which was dead. Heartbeat should be present when ground pump length is 5 mm. If it is not there, then the early fetal embryonic demise can be diagnosed. In this case, the ground pump length was 2.1 mm, and even then the heartbeat was detectable. So at 5 mm size, it should always be detectable. Mean sac diameter grows at the rate of 1.1 mm per day. And growth rate of the embryo is 1 mm per day. Mean sac diameter minus ground pump length must be more than 5 mm. The sac size and the ground pump length size. This distance should be more than 5 mm. Otherwise, the early pregnancy failure will occur. Here you see the sac size is 5.1 centimeter and ground pump length is 4.3. So the difference is more than 5 mm. So this is a good sign. Fetal heart rate is also very important in early pregnancy. Normal mean fetal heart rate is 140 beats per minute, and significant bradycardia is diagnosed when ground pump length is 5 mm and the heart rate is less than 80 per minute. If the ground pump length is 5 to 9 and heart rate is less than 100, this is also bradycardia. And if the ground pump length is 10 to 15 mm, then the heart rate, if it is less than 110, it is diagnosed as bradycardia. Here you see early first trimester oligohydramnia associated with impending fetal demise. The sac size is too small for this large embryo, and opposite also is not very good. In this case, there is a large sac, but the embryonic size is very small. Yolk sac size is also very important. If it is large, even then the fetal demise is going to occur. Here you see the yolk sac of 9.8 mm in 8.5 week pregnancy, which resulted in fetal demise. This yolk sac size is 6.6 mm. So to summarize this, early pregnancy failure, if the sac is not growing well or is irregular and less echogenic, less thick, or located very low, or if the yolk sac is not appearing, or yolk sac is abnormal, embryo doesn't appear or is dead, and if there is discrepancy in dates and among the sizes of the sac and the embryo, serial scans do not show expected progress, then missed abortion or blighted ovum or other types of early pregnancy problems appear. Here is a case it was a history of 12 weeks amenorrhea, and now patient has been bleeding for the last 2 weeks. This is the longitudinal section of the pelvis, and in this case the sac was located very low, and this sac does not correspond to the size of to the history of the patient. Here you see it is just 5 weeks, 6 days, and patient has been had amenorrhea for 12 weeks. In this case, you see some echogenic material in lower part of the uterus, and now there was 10 weeks amenorrhea and now bleeding for 3 days. And here this material was also present in the area where the C-section was done. This was the scar of the C-section. It was here, stuck here. A very low sac in the cervix. Retained products of conception can appear as echogenic amorphous type of material in the uterine cavity. Patient pregnancy test is positive. Sometimes the retained products can be vascularized, and these retained products are not going to come out themselves, and patient will need DNC. Other type of if there is just blood clots inside the cavity, there is possibility that these can come out without DNC. Also vascularized RBCs, pregnancy that thin walled sac here, no vascularity, some more RBCs lying in the cavity. In this case, there is no great vascularity, and there is possibility that these clots are going to come out themselves with conservative management. In this case, there is vascularization of the retained products of conception. RBCs. Sac is present, but there is no yolk sac or embryo. In this case, you can see a gestational sac lying very low, and in this case, the gestational sac is even just almost in the upper vagina. External arch is also even open. Gestational sac and some faint echoes are seen inside. If you see some echoes inside, then it is missed abortion. If you don't see anything inside, then it is an embryonic gestation. Here you see a gestational sac and some collection of the blood in the lumen of the uterus here. This should not be regarded as another gestational sac. Here there is a large gestational sac but no embryo, and embryonic. This patient had 11 weeks amenorrhea and now bleeding for 5 days. 8 weeks sac, bleed and there is no embryo. Here there is 5 months amenorrhea, large sac but a small embryo. Small embryo, large sac. Another case of an embryonic gestation. This is also an embryonic, but you see the residual reaction is rather thicker. In such cases, if this material is subjected to stability, some of these cases will be molar. Here, small embryo, large sac, and look at the yolk sac. Yolk sac is echogenic and abnormal. Fetal bradycardia, less than 80 per minute. This embryo died after 6 days. Heart rate was 69 per minute. We have already discussed the mean sac diameter minus thrombus length. If it is less than 5 mm, will result in embryonic demise. Large yolk sac results in early embryonic demise. The sac size is 5.4 mm. Subchorionic hemorrhage. Here is the gestational sac and the yolk sac. There should be adjacent hemorrhage here. If the hemorrhage size is very large, even these fetuses will also abort. Now we will see some of the signs of ectopic pregnancy. In ectopic pregnancy, the uterus can be absolutely empty or it can contain residual reaction and also some amount of blood within the cavity. So this is the pseudogestational sac in the cavity, and outside the uterus there can be hematoma or blood. And sometimes the blood can also be seen in the upper abdomen, in the pectoral and in lienorenal pouch. Here you see longitudinal section. The pseudogestational sac is in the uterus, the blood in the hemoperitoneum, in the cul-de-sac, and in one adnexal area you can see a gestational sac, adnexal ring containing an embryo which was alive. Here is the gestational sac outside the uterus. Pseudogestational sac is just a collection of blood within the cavity, and it has a tapering lower end, and it does not have a double wall sign of a normal gestational sac. Here you see a pseudogestational sac with a tapering lower end. Diagnosis of abnormal intrauterine or ectopic pregnancy requires correlation of ultrasound findings and lab data of qualitative and quantitative serum beta HCG levels. Here is the empty uterus, and on one side you can see a gestational sac in a distal area containing an alive embryo. On transabdominal scan of the same patient, bladder was very full and the uterus seemed to be empty, but the adnexal and Cundy sac pathology was not very apparent. The same patient, when bladder was empty, the uterus came into the focus and we could see the abnormal extrauterine adnexal ectopic pregnancy, and the uterus is empty, and there you see the blood there. On TBS it was more clear that this is the embryo and surrounded by the gestational sac and adnexal area. It was an alive pregnancy ectopic. This is heterotopic pregnancy, rather rare, in which one pregnancy is intrauterine and one is extrauterine. Here you see an intrauterine pregnancy and an extrauterine pregnancy, and there is massive hemorrhage here. This is a case of abdominal pregnancy. The uterus was empty. It contained a pseudogestational sac with a tapering lower end, just a collection of blood inside. And outside the uterus there was a fetus with head and femur. This is another case of ectopic pregnancy. The uterus is empty, pseudogestational sac is there, and on one adnexal you can see an embryo alive, and there are theca luteal cysts, alive embryo outside the uterus, and uterus contains pseudogestational sac, alive embryo outside the uterus with yolk sac. Another case of ectopic pregnancy, you see whether intrauterine or extrauterine, the ectopic pregnancy will tend to have an echogenic ring-like appearance because of the chorionic villi, which gives it a brighter appearance. This is pseudogestational sac within the uterus. Here is another case of ectopic pregnancy. Look at this echogenic area because of the chorionic villi, some uroperitoneum. Ovary is adjacent to the ovary. The empty uterus is on this side. That was the mass of the ectopic pregnancy. Another, see the echogenic appreciated. This is the ectopic outside the uterus. And there was hemorrhage, blood collection around the uterus, and in hepatorenal pouch. Another case with extrauterine pregnancy, embryo here, yolk sac, the gestational sac, hemoperitoneum, empty uterus, ectopic pregnancy, pseudogestational sac within the uterus, outside the uterus you see the collection of the blood there, and in this case there was an extrauterine pregnancy and also an intrauterine heterotopic. There was hemorrhage there also. One more take home important point is that whenever you see this pseudogestational sac, many people will regard it as a true gestational sac, and they will do DNC and throw away the material into the bucket. Whenever DNC is done, after going through such a hard and difficult task and expense, that material should always be subjected to histology. Because when histology proves that there are chorionic villi, then that means that it is a true intrauterine pregnancy. And in true intrauterine pregnancy, the incidence of extrauterine additional pregnancy is very, very low. So that makes it very important to not throw away the DNC material. It should always be subjected to histology, And if one can see the chorionic villi, one